All right, I think we are officially recording, FYI. So what are we thinking?
C. I agree with C.
Anyone else?
I agree with C too.
All right, good deal. Tell me why C. Tell me why not A, B, or D, and what principle did you use?
I guess you could use the one of these things doesn't belong and one's like the other.
Yeah.
Um,
What was
your
different?
blood
A, B,
pH.
C, D?
Sorry.
No, you're
Your
fine. Go ahead.
your blood pH doesn't really belong with your wound. Um, I'm thinking more like ABGs for your blood pH, so that's not what I would be looking at for your wound. And hematocrit and platelet, I just kind of looped together. Your white blood cells is looking at your infection for your wound.
Okay. Very good. Is that what everyone else saw? All right.
Yes.
Someone did see something different that was a correlative factor that we could have used? Or are we just ready to go to the next one? Let's go to the next one. Let's do this one. Oh, I see a problem here. It's not diabetes insipidus. It's diabetes mellitus. That'll make a difference. All right, so really quickly, because we have a friend who is listening in and needs for me to read the question because they are not able to see the screen. After several days of coughing and taking acetaminophen to treat temperatures of 101, a client with diabetes is admitted to the hospital with an upper respiratory infection. Several hours after admission, the client reports having a severe headache and feeling dizzy. Which intervention should the nurse implement first? Are we going to A, reassess vital signs, B, obtain sputum for culture, C, obtain a finger stick glucose, or D, administer an antipyretic?
C.
C.
D is in dog?
C.
Okay. Let's see what my chat box says. C. All right. Answer is A. So let's go back and let's look at this. After several days of coughing and taking acetaminophen to treat temperatures of 101, a client with diabetes is admitted to the hospital with an upper respiratory infection. Several hours after admission, the client reports having severe headache and feeling dizzy. At any point, have we given any vital signs?
No. Well,
But
your temperature, but
we knew that after several days of coughing and taking acetaminophen to treat temperatures of 101, so we know he's got a history of, but at what point have we established what our vital signs are for this patient in the current moment? So several hours after admission, the client reports having a severe headache and feeling dizzy on top of already getting his baseline vitals. So when we know this and there's a change and it's an acute change, right, we have to do a focused assessment, right?
Okay.
Always with a focused assessment whenever we have an acute issue. Does that make sense?
It's confusing, but
So is it? Think about it. if we're talking together during lunch and everything's fine, and then I come back 5 minutes later and I'm limping, what are you gonna do?
Checking vitals.
You're gonna ask me why I'm limping, right?
Yeah.
So what's the difference between that and then we say we're a nurse, we put a nurse hat on and we have a patient in front of us? What's the difference? The uniform. That's it. Because nursing's what, guys? I got 18 babies in here. One of y'all know this answer. Nursing is what, guys?
Common sense.
Thank you.
Common sense.
Thank you, my babies. Nursing is common sense. Because guess what, friends? We do it every day on our own without the RN next to it. We're already wired for this because this is what we do. This is who we are. This is who we were born to be. Okay. So, do we understand why it makes sense that we would reassess vital signs before all the other stuff? Because we don't know if we need an antipyretic because we knew that he had a history of it a couple of days ago, but we don't know what we got right now because it doesn't say. And if it's not there, it ain't there. Wasn't that a principle? What was the principle called? Someone look that up. Please. I forgot my principles. I forgot my innovative way of doing this. All right. So let's move on to another one. Does anyone have any questions about that one? Does it make sense? Friends, did I lose you to the alien invasion?
It makes sense.
Cool. All right, so here we go. A client takes daily supplemental iron tablets for iron deficiency anemia, reports feeling increasingly fatigued. Which laboratory values should the nurse review? Should we review A, serum electrolytes, B, CBC or complete blood count, C, liver enzymes, or D, platelet count?
B.
Anyone else?
I agree.
B.
Good job, B. Perfect. Do I need to explain out this answer or does everyone got it?
Yeah, good.
Good to go? Okay, cool. There we go. The nurse is caring for a client post-anesthesia care unit or a PACU who underwent a thoracotomy 2 hours ago. The nurse observes the following vital signs. Heart rate is 140. Respirators are 26. Blood pressure is 140/90. Which intervention is most important for the nurse to implement? A, administer IV bolus as prescribed by the healthcare provider. B, immediate or medicate for pain to monitor vital signs according to protocol. C, encourage the client to splint the incision with a pillow to cough and deep breathe. Or D, apply 10 liters non-rebreather mask and monitor pulse ox.
I'm saying B.
B. B.
As in boy.
I agree.
B is in boy. Very good. So why is this no good for A, B, or C? Or A, C, or D? Sorry. Somebody give me the answer to that, please.
I don't think it's indicating that they're dehydrated for A.
What would an increase of 1 liter of fluids do to this blood pressure?
Raise it.
Yeah, to a stupid rate, right? And we're already walking some very fine territory. We already have increased respers. You know, if I rack up your blood pressure a little more, is that going to be indicative of an increase of respers? Well, if I'm doing that, what am I doing to everything else? I mean, it's kind of a gamble, right? So we definitely probably wouldn't do that right that second when we had other options, which is medicate for pain, because every indicator says so. Good. I don't think we really need to talk about the other ones because I think they're pretty obvious. You don't want to blow someone's lungs up when they're perfectly fine. and it doesn't say anything about O2 sat, and splitting an incision with a pillow. That wouldn't even be a conversation this close into the game. All right. How about this one? And that is diabetes insipidus, FYI.
D.
Okay. Anybody else?
I agree with D.
All right. A nurse is caring for a client with diabetes insipidus. Which data warrants the most immediate intervention by the nurse? A, dry skin with an elastic turgor, apical rate of 110, polyuria and excessive thirst, serum sodium 185, yowzers. D is the answer. And probably D is the answer because I just said yowzers, because what are our sodium levels that are normal, friends? That is not me having an extended toot. That is me not WD-40ing my couch. Okay.
135 to 145.
Very good, right? So 185. At that point, I'm expecting what to be going on with this patient?
So how do I
Heart
hypotonic?
problems.
Well, what is the person with 185 sodium going to do? Let's recall that because this is part of exit HESI. Too low a sodium, we get this. Too high a sodium, we get that.
Hypo,
High
hypo,
sodium fluid
Yeah.
overload. Is it hypervolemia?
So if
Or
I am in
is it
diabetes
the opposite?
insipidus, I'm peeing so much that all that's left is sodium. So what happens when I'm hypernatremic? Somebody give it a Dr. Google. Let's see if we can figure it out. I'm stopping you because sodium is one of those questions you're going to see often on your NCLEX. Sodium is going to be one of those questions you're going to see often on your exit. So we need to understand this principle right now so that we don't accidentally walk over it later of hypernatremia versus hyponatremia and your signs and symptoms and differentiation, because this one comes up a lot. So I'm going to
This
take
is just me guessing, but with hypernatremia, your sodium's too high, so you're going to have high blood pressure, tachycardia, increased thirst to try and balance out the amount of sodium that's within your body.
How does everyone feel about that? If I'm dry, I have dry
Agreed.
because I'm nothing but salt, right? Altered level
Mhm.
of consciousness because I'm irritable. I don't understand what's going on because I don't have the fluid I need and those spaces that need to be bathed in that fluid. Period. Point paragraph. I need isotonic. I'm not getting it. You're going to have tachycardia. You're going to have insufficient urine production unless you got DI, and then you got nothing but a big old headache. You got irritability. All right. What about hypo?
The opposite.
Listen, Linda. Listen, Linda. Why don't you tell me specifically what that looks like? Think about energy, frequency, and vibration. It's one of our principles. If I am hypo, what is my energy doing as well?
Decreasing.
Correct.
Yeah.
So I'm slow. I have confusion issues. I have, what else?
nausea.
So
And
is your heart rate slow? It's
I'm
slow.
lethargic. I kind of ache everywhere. I'm super thirsty. All of these things, if things aren't going well enough, I'm slow. All right. Now, backing up the train just a second. Which one of these causes tetany and which one of these causes tendon reflexes that are decreased? And stupor coma. Which one's the scary one? Hyper or hypo?
Hypo.
Hypo, and here's why. If I'm pulling a nutrient out of your body that you need to live, what happens? You start to slowly die. Just like if your hypo, energy, frequency, and vibrational pattern states that you will have a lower energy, lower frequency, and carry a lower vibrational pattern within your body, much like being hyponatremic. So you're going to be lethargic, you're going to be stupor, comatose even, okay? Now, think of hyper, and then what is hypernatremia going to cause at its opposite end that's also just is equally as scary?
Hmm.
Y'all think I'm playing, y'all better Google it.
Hemorrhage.
Seizures.
Thank you. Thank you. What is seizures? What's another way of cause it? What is another way of explaining a seizure? What
A
is it?
misfire. A
It's
misfire in the
misfire.
brain.
Something is so fast, it's like AFib for the brain. If AFib in the brain happen, it would be a seizure, is the only way I can explain it, right? We're rapidly firing, we have no rhythm, we have no pattern, we're just all over the place, just like AFib. AFib of the brain is a seizure. It is from excitability. It is from high intensity vibration frequency. You guys got that? So even if you don't know the answer, you can still figure out the answer. All right. I think I've hit it until it can't be hit anymore. All right. How about this one?
B.
A.
A.
Yeah. Okay.
I agree with A.
All right. The nurse assesses a client with petechiae and ecchymosis scattered across the arms and legs. Which laboratory results should the nurse review? A, platelet count. B, red blood cell count. C, hemoglobin. D, white blood cell count. And we have A is the answer. Do I need to explain that one, or we all got that? Everybody feeling good, feeling great? Feeling great, feeling good. How are
Yeah.
you? All right. Let's move on. You guys are doing really well. How do you feel like you're doing?
I feel like it's too easy so far.
Okay. Or that you are fully prepared and you just don't realize it. Okay, cool. Cool. How were your questions in comparison? Were they about the same? I'm curious.
Yeah, I feel like a lot of the questions on the exam were more general safety and patient care related versus laboratory and statistics.
There was a lot of med question today. I think she said there was 21.
Okay. All right.
Yeah.
And luckily you guys really covered working on that PowerPoint and all those medications really well. So I had little to nothing to add. Good job. I say keep using that methodology and keep using that strategy, because I have a good feeling that's going to be a good battle strategy for you guys.
It was great.
Cool. All right. What do we think about this one?
C.
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 Okay. Very good. All right. A client is hospitalized after experiencing an MI to reduce cardiac workload. Which intervention should the nurse include in the client's plan of care? A, teach to sleep in a sideline position. B, encourage active range of motion exercises. C, provide a bedside commode for toileting. Or D, assist with ambulation in the hallway.
C.
C.
B.
Okay. C is in cat. Did I have anyone else answer anything other than C? I think I heard a D, but it might have been an accident. So let's talk about it just in case. All right, so why is assisting with ambulation in the hallway not a good idea for cardiac workload?
It will increase it.
Correct. And assisting the patient with ambulation, this follows the principle of can you elaborate? Because how much are we assisting exactly? Do we know? No. We have no idea. I don't know if they're just giving me a spot. I don't know if they got a wheelchair back behind me because I'm about to pass out and they know it. I don't know if they're giving me a fair mod assist or a max assist, right? So kick it out of the curb right off the bat. Teach them to sleep in a sideline position. What is this going to do for cardiac workload?
Uncomfortable.
So what about encourage active range of motion exercises? Is this going to increase the workload or decrease the workload?
Increase.
Increase.
Oh, so all that's left, one of these things is not like the other, one of these things does not belong, is C. Provide a bedside commode for toileting, because that will decrease the workload because they won't have to walk all the way to the bathroom. Easy peasy lemon squeezy. Lasagna is good if it's extra cheesy. All right, cool. How about this one? Sorry, I made lasagna today. It was really good. All right, friends, what do we think?
B.
B.
Okay. Give me just a second. Sorry, I'm doing attendance right now because that's a thing. Cool. And drum roll, B. Good job. Does this fit any of the principles you can remember? Can anyone remember the principles without looking on the WhatsApp?
Can like the new people in this get that? Because I don't think
Yeah,
some of it.
the
I
principles.
remember some of them from last quarter when I would like come into the exit HESI ones, but I don't remember all of them.
It's fine. So
Yeah, I only remember like one or two.
the 7 principles are super important. It helps us crack the code of how to answer a question. The first principle is one of these things is not like the other. One of these things does not belong. It fits about, I don't know, guys. What do you think? About 80% of the material I teach you follows the principle of one of these things is not like the other. One of these things does not belong. I say 80 or more. And that's where you have 3 answers that are correlated somehow. Like we had a question earlier and our options were related to red blood cells, A, B, and C were, whereas, or A, B, and D were, whereas C was white blood cells, right? So a commonality between the 3, which are absolutely inaccurate answers, and then only leaves one, which is usually the opposite to the extreme. In the last case, red blood cells versus white blood cells, right? So that's principle number 1. Can anybody remember any others? Or
Your active versus passive.
goes active versus passive. All right, so active versus passive is number 2, right? I believe it's number 2. At one point, we got them all mixed up, but principle 2 is active versus passive. And it's the idea of the answer bank is going to give you an active action versus a passive action. When we get to a question like that, I'll stop and explain because I want you to know this one. This one's super important. And a lot of times our passive actions say things like we're going to describe something to the patient. We're going to interview the patient. We're going to evaluate something, right? We're doing sissy things when we should be doing active action, which is I am changing the order to, I am educating, I am using teach back, things that are powerful in its ability to change the dynamic of that patient's care. Does that make sense?
Yes.
All right, cool. Stay with those two for right now, and then we'll keep moving forward. And when we find one, we'll call it out. Have we answered this one? I can't remember. I don't think we have.
We did.
Yikes. All right, cool. Sorry. I get into a tangent of talking and then I forget where we're at. All right, go ahead. Any takers?
D.
D.
Okay.
D.
D is in dog. Why is it D is in dog? Tell me, someone educate me on PUVA treatment.
I don't know what the P stands for, but I know it's a light treatment, the UVA rays.
Good. So then why would A, B, or C not make any sense?
B would be your psoriasis, with the silver scales. Um, D is like your sunburn, your tender and red. Um, A is I forget what they're called, like the keratoses, um, like the age spots, I think.
Yeah, look at you. Good job. Yep.
And then C is with the eyes, and that's not really your skin. Your eyes are usually protected during light treatments.
Very good. So a PUVA treatment is a Sorelins, right? UVA treatment. And they're compounds found in many plants, which make the skin temporarily sensitive to the UVA. All right. Believe it or not, Egyptians used it back in the day to treat skin diseases like crazy things like leprosy, sometimes even just to see if it worked, 10,000 years ago. So this has been going on for a hot minute. And there's different variants of those different plant derivatives that they use genetically, yada yada yada. But that's the idea of it. But again, how can you break this question down, even if you don't even know what PUVA is? How could you use the principles by answering by looking very quickly and going, okay, that's this, and this are directly correlated with one another? Can anyone see that?
You're one of these things are not like the other
Yeah,
again.
yeah. So what I see when I see A, B, and C is I see, well, when you got plaques, it's going to be the color silver. When you have papules on the face, they're going to be brown, rough, greasy, and wart-like. You're going to need sunglasses because looking in the sun's going to hurt your eyes. Okay, cool. Got that. That makes sense. If I kick my leg's going to hurt. Perfect. Right? But tenderness upon palpation and generalized erythema, what is that all about? Make sense? All right. How about this one? All right, friends, any takers? Come on, don't be shy. You guys got this. And even if you don't, we'll talk it out. It doesn't matter.
D.
B. Anyone else?
I think B as in boy.
Okay. Well, let's look. B is in boy. Did I hear a D is in dog earlier? So this covers a lot of real estate. So let's go over it. A client with a history of chronic obstructive disease or COPD is admitted with pneumonia. Vital signs include oxygen saturation 89%, temp is 100.5, heart rate is 120 beats per minute, respirations are 28, and blood pressure is 170/90. I mean, yikes a mundo, right? We got a lot going on, which finding warrants immediate intervention by the nurse. Shortness of breath on exertion. Okay, cool. I think we can establish that with oxygen saturation at 89. Bilateral diffuse wheezing. Okay, cool. We got pneumonia. That's what it's supposed to sound like, right? Or it's a COPD with the striated lungs. So it's one or the other. More than likely, pneumonia is more wet. So more than likely, now that I'm looking at this again, I'd probably say it's a COPD and exacerbation. All right, cool. Yellow expectorated sputum. All right. What do we know about yellow expectorated sputum?
It's an infection.
Cool. Also known as dun 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 dun. There she be. So all that's left is coarse breath sounds. Make sense? Cool.
Yeah.
All right. Here we go. Do we need a break? Can we go potty? Do we need a 5-minute break to go potty?
Molly, are you going to go over the 5 steps? I don't have all of them.
So I actually have a habit, and a bad habit, I might add, much like Nikola Tesla, of coming up with a genius idea in theory and then forgetting to write it down. But I do know that we had a WhatsApp last semester, and I do know that one of my super dedicated students is listening to me right now and knows that I am talking to them specifically because they basically
I'll send it to you.
Thank you, darling.
You're
Who-
welcome.
Sorry, we're recording.
Who's gonna
so I
send-
can't use names, but you know who I'm talking about. Come on, friend. And I swear I put it in there at least 3 times. And they actually helped me develop a couple of them. So if you find any correlative factors that are not part of the principal list, please let me know. We're always trying to find something new, and we do find them often. So what we got with this little buddy right here?
B.
Anyone else?
A.
Okay.
A.
All right,
A.
A. D.
Dog.
O.
D is in dog. Everyone's super confused right now. Everyone's mind blown.
Can you explain further, please?
Up, I got you. The nurse observes an increased number of blood clots in the drainage tube of a client with continuous bladder irrigation following a transurethral resection of the prostate or a TURP procedure. What is the best initial nursing action? Initial is the key word here. All right. So increase the flow of the bladder irrigation. What's that going to do?
It's gonna flush it out faster at a
It's gonna
higher
flush
rate.
it out faster. What color is our urine supposed to be during a TURP procedure so that we're not interrogating it?
Isn't it like a pinkish?
It is a pinkish. Very good. So we have blood clots. Is that to be expected with the TURP procedure?
Yes.
But we don't want them so nasty that we're going to increase the flow. And as we increase the flow, we increase the turbulence within the urethra. And then if we increase the turbulence within the urethra, what's going to happen?
That can get occluded.
So it will do the opposite, and it can actually become turbulent, scratch the sides, and cause bleeding. Think about it. Has anyone ever flushed a catheter before? If you flush it too fast and you push it in too fast when you flush it, you could actually cause a lot of turbulence and damage and cause the bleed. It's very sensitive tissue in the internal structure. Very, very sensitive. So if you piss it off in any way, it's going to bleed back. So if you increase that flow, you also potentiate increasing the amount of turbulence you're going to put through that urethra and the amount of trauma you're going to produce within those tissues. Does that make sense?
Yes.
You gotta be real careful. That's why they say make it pink tinged and not clear. Because if you run it clear, you're killing the inside. All right. B, measure the client's intake and output. All right, that's got nothing to do with increased blood clots. Well, it kind of does because it goes back to the intake part. Administer a PRN dose of an antispasmodic agent. That's going to be regardless, and that's got nothing to do with this issue specifically. Provide additional oral fluid intake. Why would oral fluid intake help with the number of clots?
Because it's going through your urinary system and then you're naturally just flushing it out.
Thank you. The blood, recall, if you're severely dehydrated, what is the sign and symptom of severe dehydration? What are you going to do? What are you going to have in your urine?
Dark urine.
Eye or blood, right? Hematuria is one of the signs and symptoms of, having a collective issue with your kidneys, right? So you got to make sure you're also providing oral intake to make those kidneys work, because we're flooding the gates with one independent system, which is the pieces and parts itself, but we forget about the kidneys along the way. We're not doing anything to do anything to the kidneys, right? Does that make sense now?
I have
Yes.
a question, Molly.
Go.
Can you give me an example of that type of drug?
What do you mean?
It says administer a PRN dose of the antispasmodic agent.
Well, we use a couple of them. Let's see what the new latest and greatest is. Give me just a second. It probably is the same old stuff we used to use, because I haven't done this in forever. For terp, not for trip, for terp. Yep. So looks like they're still using alpha blockers. So things like Flomax they'll use. And it relaxes the smooth muscle and stops it. They also use Uraxatril, Credura, things of that nature. Does that help?
Yes.
Okay. I'm looking to see if there's anything else that's fine. And I'm not seeing anything super exciting. Bentyl, but that's for IBS. Yeah, I don't see anything super exciting beyond that. Sorry. Belladonna, but again, that's for IBS. Ha. Save the day again. Hey, could you do me a favor? Did you already put it in the chat before I even need that? I love you. God, I love you. Already done. All right. So if you go into the chat, the 7 principles are listed. It's also conveniently listed in my text, which means I'm going to save this screenshot immediately. Thank you. Done, done, and done. So these are the 7 principles. So put those down. The ones I've explained, keep it. The ones I haven't explained, we're going to get there, so don't worry about it. Do I need to keep on with this question, or can I move on to the next? Do we need a break? We still have half an hour to go.
Let's just keep going.
Okay. All right, how about this one? Any takers?
I'm
B.
guessing B because you should have hypoactive vowel sounds. They shouldn't be completely absent.
I was gonna guess C.
Okay. Well, let's see. C is in cat. All right, so let's talk about it. The nurse assesses an adult client 24 hours after a bowel exploration and formation of a sigmoid colonoscopy. That's spelled wrong. Okay. Which assessment finding should be reported to the surgeon? The fecal matter is brown and has a solid consistency. I would make a joke right now and say, well, no, but I'm not going to. But that would have been really funny if I did. I'm just saying, but I didn't because I can't. All right, there are no bowel sounds in the left lower quadrant. So what is also contained within the left lower quadrant that we were just having a bowel exploration and formation of sigmoid colostomy? Or yeah. What quadrant is the sigmoid colon in? It's in the left lower quadrant. So would that be an expected finding? What is an exploratory surgery? It's where you poke and prod around, but not really, but you explore the area to see what we need to do. And we're going to start a formation of a sigmoid colostomy, which means what? Peristalsis is going to be slowed or stopped temporarily, right? So we're making a stoma. Now the stoma, if it's purple, what does it mean?
Infection?
No, not
I was
in.
thinking no blood flow.
Necrotic.
So whenever we go purple or black, we go into necrosis. So this is no longer an issue of an infectious process. This is an issue of constricted blood flow and death of that tissue. And it's seen by seeing purple. A stoma that has streaks of bright red blood, it's a brand new. I would expect that to be a finding. If it's cherry red and oozy and glistening in the sun, that's exactly what I want it to be. If it's purple, things are dying, something's too tight. Does that make sense?
Yes.
Cool. And again, we're just getting back in the motion. So don't start kicking yourself in the teeth if things aren't going well, because we're reading the language again, right? We had some time off. This is our second semester French class. It's okay.
So I feel like I want to say C.
Okay.
I agree with C as well because the findings kind of sound along the lines with compartment syndrome.
Okay. All right. Cool. Let's see. C is the answer. All right. So, friend, who I know your name because I love you dearly, why don't you go ahead and tell me a little bit more about what you were about to get into? Tell me the principles that make the answer stick out like a sore thumb, and tell me where your brain's going as you're reading the question.
So as I'm reading it, I'm seeing that he's reporting severe pain, which can be from the lack of blood flow caused by compartment syndrome. And then with lack of blood flow, you're going to be change in color. So that's the blue and blanching. And with compartment syndrome, the only way to kind of reverse the problem is a fasciotomy. So you need to release all that pressure that's built up. Just by taking the weight off, I know that wasn't going to be it, because the pressure within the certain body part that's affected is still going to remain there. And I used the 5 Ps.
Very good. I'm very proud of you. That was amazing. Does anyone have anything else that they'd like to add, or anything different that they see that might be helpful for everyone listening?
I guess I would like to add, I think with the, aren't you like, you can't touch the tractions, that's why A is also locked out. Like, don't you have to have a provider's order to release anything that has to do with the traction?
Oh, yes, ma'am. Yes, sir. Yes, non-binary. You bet your sweet. You better have a physician's order to make any changes in traction at all. Yes. Good job. All right, here we go. Let's do another one.
B.
Anybody else?
I agree with B.
Okay, let's look at it. B as in boy, very good. And then can I have a friend to go through it with me?
So I just always associate leukopenia with cancer. And with receiving the chemotherapy, they're going to be immunosuppressed. So I'm going to be worried about the risk of infection for them.
Very good. So someone asked the question in the chat box, why would we not want to touch skeletal traction? Let me just back up for a second and explain what that looks like. So skeletal traction, it's meant to do a couple of things. It's meant to put us in a position where we can hold off surgery. Why would we need to hold off surgery? I'm so glad you asked. So I had a phenomenal orthopedic surgeon in Athens at a hospital I was a traveler at, who taught me a whole bunch, and I'm eternally grateful to them, and they're genius because they were quite phenomenal. And the way that they explained it to me was, hey, Molly, when you thaw out hamburger meat that you put in the freezer and you leave it out, why would you not want to slice into the side of it? Why would you just want to cut it in half and then open it up? And I said, well, because all the stuff is going to just come spewing out. And he's like, right. Sometimes we need to let the inflammation just do its thing and chill itself out. So that's why we have patients for days that will have a fractured hip, but no scheduled surgery. It's not because the surgeon's being a jerk. It's because they're waiting for that inflammatory reaction to go down. Does that make sense?
Yes.
So what we'll do is we'll put someone in skeletal traction. It's meant to do a couple of things. It's meant to stretch so that we don't we're not in a state of atrophy. It alleviates muscle spasms. All right. It keeps things held in place appropriately. Does that make sense? So pain management and pain relief is our priority, and we do not touch skeletal traction for that reason. They have those traction weights hanging freely. They know how much weight needs to be pulled and pushed, and the traction that needs to happen in the internal structures to keep things from busting apart, things not sticking like they're supposed to or being set like they're supposed to, et cetera, et cetera. We never mess with those. I hope I answered that question for you. Cool. All right. Let's move on to the next one.
A.
Anyone else?
A.
Okay, very good. I don't feel like I really need to explain this one. Does anyone need explanation for it? I can. Okay. My water is out. It is 9:08. I've been talking for 2 hours now, and I have another class that starts at 9:30. I'm gonna give myself a 5-minute break. I'm gonna give you guys a 5-minute break as well. So you guys shake around a little bit, and then I will see you in 5 minutes, and then we will finish off with a couple more questions.
All right.
Cool.
Yes. Thank you.
Okay. I have no idea if that was 5 minutes or not, or even longer. So do you want to do one more question? And then we can talk about the principles, and then we can be done for the evening.
Yes, please.
All right, cool. Because after this is farm. Woohoo!
That is still a question that we just did, if you're waiting on us.
Yes, I am. Snap, crackle, and pop. I am so sorry. It was a trick question. No, really. My ego needs it. I'm joking.
D.
I agree.
Okay. D it is. Very good. All right, so let's go back to these principles and go over them very quickly. So one of these things is not like the other, one of these things does not belong. Everybody knows that one. Passive versus active, I just explained. No all, no never. So in no all, no ever, we're going to have questions that are going to give us an answer bank that are going to use the words all or never. Now, I have mentioned this a couple of times. People say there is such a thing as all people die. And I go, really? Because the reason we have a vaccine for HPV is because the cells of a woman who was deceased were remaining alive through their own evolution, right? And of course, through genetic help, they were living. So therefore, you can't say that the person is truly dead, right? So if you see all or never on a test, don't go for it unless it talks about patient safety. And even then, I wouldn't do it. And here's why. Can we make all patients safe?
No.
No. Can we make our goal to provide patients, all patients, with the same equality and safety and give them that same opportunity? Technically, yes.
Yes.
Still wouldn't even touch it. I'm just telling you. No all, no never. Let's see. Parasympathetic versus sympathetic. Does everyone understand parasympathetic versus sympathetic and how that's important to this examination or any other examination you take? Because if I need to explain this, it takes 2.5 minutes for me to explain. It's very blunt and clear. And this is one of those processes that's going to take you throughout the course of your existence. So if you don't know what I mean when I say parasympathetic versus sympathetic, please give me 2.5 minutes to explain it. It's worth it.
I
Is it-
would, please.
All right, so parasympathetic and sympathetic, these are the two processes that your autonomic nervous system and your brain works with, right? There are more, but basically this is the main two that drives our reaction to a stimulus, all right? So sympathetic, I want you to think of whatever you're afraid of most, right? And I like to think of it as Freddie and Jason are behind me and I'm covered in bees because I dropped on a hive, right? And there's honey everywhere. And these guys are coming at me and they're barely even, breathing. And here I am tripping off of trees and so on and so forth, right? Looking like a goofy person about to die. So is my heart rate elevated or is it lower?
Elevated.
Cool. Pupils dilated or constricted?
Dilated.
Dilated. I'm trying to see everything around me. I ain't got time to knock into things. Perfect. Peristalsis. Is it moving? Is it stopping?
Moving.
Now, do I have time to pee and poop while someone's trying to slash me to death?
No.
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 The peristalsis actually slows. I ain't got time to sit and squat. I'm about to get cut in half for all I know, right? I got Freddie and Jason coming after me. That's not going to go well. All right. So then let's do parasympathetic. Parasympathetic is a state where I'm relaxed. I'm in the woods. It's just me and nature, and I'm 20 miles in the middle of it, right? I'm not getting out of it. There's not a cell phone in sight. I'm cool, right? I am super happy with life. So in that instance, heart rate, higher, lower.
Low.
Lower.
Thank you. Respirations, high or low.
Low.
Pupils, constricted or dilated.
Restricted.
Cool. Peristalsis, moving and grooving or nothing. I'm resting and digesting. My peristalsis is fine. So these are the principles that you need to understand the world around you. Well, why do I need to understand that? I'm so glad you asked. Well, it's simple. If I have a person who is in a parasympathetic state, only it's so bad that I would consider it a hyperparasympathetic state, which is they're trying to die on me. In an example, I have a patient who just got out of surgery. They got a PCA pump. They're hitting it, and then I give them some breakthrough pain medication. All of a sudden I go check on them and their respirators are 8. That's hyperparasympathetic. So what do I need to do to immediately put them in a state of sympathetic nervous system response so they don't die?
Naloxone.
Yeah, I'm going to give them meds, naloxone specifically. Good job, buddy. I'm going to have to shake them and quake them and get them moving and grooving and get them angry. Because if I got them angry, I've got the heart rate elevated. If I've got them angry, I've got their respirations elevated. Do you see what I'm getting at here? You picking up what I'm putting down? This is the idea of parasympathetic versus sympathetic. If I have a patient who is in a parasympathetic process or hyperparasympathetic process, they are so chill that they have stopped breathing. And then if they are in a hypersympathetic process, then they are an SVT. So all I need to do is know the inverse, or if I'm going from sympathetic to go to parasympathetic, I know that I got to chill them out, and the inverse for the opposite. Does that make sense? So energy, frequency, vibrational pattern. Energy, frequency, and vibrational pattern are throughout this entire examination. They give you trigger words to let you know if a person has a low vibration or a high vibration, a high frequency or a low frequency. In an example, when we talk about frequency, we have issues like monitors. It's going to ask you about monitors in these tests. So if I have a child that's screaming, I can hear my child over any other child. That's the idea of frequency. My child's frequency is tuned into me. Their vibration is tuned into me. Their energy is tuned into me as their mother. So much like that, you are a mother to these patients who are your children in essence, because they ask for a lot of things. They're really ticky. They're kind of going through the terrible twos because they're in pain and they need things, right? They need for you to help them and coddle them and make them better, right? Same principle of mother and child. Different people, obviously. So in this instance, I'm going to have alarms that are going to go high pitch, much like my child, because that high pitch alarm is meant to trigger something within me that says danger, danger, danger.
House.
Wait.
Everybody on mute. So danger, 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 high frequency. Low frequency, I'm not so worried about it, but it needs looked into. So any high frequency alarm in a hospital is going to be an alarm that is going to be critical to someone's life. Prime example, ventilation. If I have someone stepping on my tube that is getting oxygen to my patient, it's going to have a ventilator alarm, and it's going to be so high pitched that it ticks everyone off in the whole unit. Make sense? Energy. If I say something is hypo, is that low energy or high energy? I'm a boring teacher.
Low.
Low. So then how am I going to be? I'm going to be lethargic. I'm going to sound like Eeyore. My blood pressure is going to be low, right? Versus high vibration, which is kind of like what I am, right? In a bottle all the time. So I'm alert. I'm oriented. I'm hyper alert. I'm hyper oriented, right? Things of that nature, energy, frequency, and vibration. So if you look at your answer panel and your answers give you high energy, frequency, vibration, high energy, frequency, vibration, high energy, and then one gives you low, using the principles of one of these things is not like the other, one of these things does not belong, you can easily deduce that your answer is going to be the one that fit both of those principles. Duh. Make sense?
Yeah.
Okay, cool. And the church said amen. Can you elaborate? Can you elaborate happens a lot. I'd say it happens in about 20 to 25% of your questions. Just like earlier, we had a very bland answer that was sitting around. And the first thing I think was, well, can you tell me about that? So it'll say something about a patient fell. They have a history of diabetes. What's the first action that you need to do? And your options are going to be, should I check for bleeding and bruising in any areas, right? Call 911 will be one of them. Take a blood sugar would be another one. And don't move the patient until the ambulance gets there will be the fourth one. Well, in this case, when we're elaborating, it doesn't tell me that the person fell because they were cold and clammy. So can you elaborate what I'm supposed to be doing here? Can you elaborate why I need to do a blood sugar? Furthermore, it'll say a patient had low blood sugar. How low was it? Is it 60 low? Is it 59 low? Is it 4 low? So that's the idea of, can you elaborate? If you don't give me details, I'm not even picking you. If you say things like weight gain, you're not telling me how much weight gain. I don't care about that answer. I'm kicking it out. Make sense? Left, right, center is more complicated. I'm not going to give you left, right, center right now because we haven't had a question that looked like a left, right, center question. The left, right, center question is another 20 to 25%, but it's equally as important because when you're in between two answers, left, right, center is going to show you which is the better answer, and you're going to easily select it when I show you the principle. But first, I need to have a question that has that type of answer bank. And those are the 7 principles of these examinations and cracking the code to the HESI or any other standardized testing in nursing. It's very simple. Sounds complicated. It's not. Okay. So it is 9:25. I'm going to open the panel for questions for the next 5 minutes, and then I'm going to have to move on to pharmacology because I'm teaching that until 11 o'clock. Woohoo! Any questions at all? Because if not, I'll give myself a 5-minute break.
Will you be back on next Wednesday?
I can be. I don't know what classes I'm teaching. I don't know what classes need taught. This is the first week I'm starting. So I'm trying to keep them all on one day, but we all know what happens when I try to do that. So I'm going to try to keep them as contained as I can. And you guys can help me by letting me know what you need and what you're struggling in. But for right now, I'm teaching leadership, exit HESI, pharmacology, and I've added foundations already because that seems to be everyone's target areas.
What days are you teaching foundations?
I'm doing foundations starting the 8th from 8:30 to 9:30.
So August 8th from 8:30 to 9:30?
Correct.
Okay.
Is it Wednesdays?
I'm sorry?
Is it going to be on Wednesdays the same?
So as of right now, they're going to be on Wednesdays. I'm going to do next Wednesday because this seems to have a pretty good turnout. If there's another day that I need to do because another day is better and I can get a better turnout, I would prefer to do that day, but it's going to be every Friday. There's going to be new ones posted on Canvas. And if you guys are a part of the old WhatsApp, I can also post it there as well and let you know when I'm doing classes.
Okay.
But
Thank
please
Okay, so
understand,
we can count on next Wednesday being the exit HESI continuation.
for right now, yes. For next
Okay.
week, that is accurate. I will be doing leadership from 7 to 8. I will be doing exit HESI from 8 to 9:30, and then I will be doing farm from 9:30 to 11.
Okay.
Cool.
Mm-hmm. Thank you so much.
No worries. All right. If I have
Thank you.
no problem. If I have no more questions, I'm gonna go ahead and give everyone a break. You guys can come back for farm, or you can kick out and get some rest. And then we're gonna start back at 5:35 after.
Okay.